Okay. Dr. Porter's gone today, so I'm by my lonesome, and but we have lots of help back here. So cough. What do you guys think of, and what kind of questions should we ask, and what's in your differential? It's a common complaint, right? Very common complaint.
When did the cough start?
Good.
Is the cough associated with any other symptoms like chest pain, problem breathing, running nose, any upper respiratory tract infections, sore throat,
Productive.
postnasal drop,
Yeah.
productive?
Postnasal drip, because we're going to see a lot of that right now, right? Farmers start going back in the field, stirs up all kinds of allergens. Very common.
Sick contacts.
Good. Sick contacts. So we have postnasal drip. What else is in your differential?
For chronic
GERD.
cough,
Chronic cough, yeah.
acid reflux,
GERD.
symptoms,
Asthma.
Asthma. What else?
Medication changes.
medications.
Medication's good. Got a guy that I saw him last week. He had a stroke a year ago. He's got hemiplegia. His wife's taking care of him at home, and he's coughing all the time.
Aspiration.
Good. Aspiration. Yeah, exactly.
Laryngeal dysfunction.
Yes. And then there's a couple others. Does anybody have a smoker here at the VA?
No.
No. So COPD.
COPD.
Okay. What about lung cancer? The most common symptom of lung cancer is chronic cough, but very few chronic coughs are cancer, right?
Yeah.
So that's something we have to think about too. So most of the time we find a cause for chronic cough, right? How do you sort it out?
History actually will help us most of the time differentiate.
Yeah, exactly.
Medication reviews,
Yeah. What medications are you guys worried about?
ACE inhibitors.
Yeah, ACE inhibitors. Okay, so ACE inhibitors.
Frequent over-the-counter stuffs for nasal congestion would give us a good piece of their history as well. If they're getting a postnasal drip or some sort of either chronic rhinitis or chronic sinusitis.
Yeah, is the chronic postnasal? That's not usually hard if you just ask, right?
Yeah, yeah.
And do we need to do any imaging for those people as postnasal drip, allergies? What do you guys want to do?
Physical exam.
Physical exam, and then I just do empiric treatment.
Yeah.
And what do you guys want to treat them with?
Second generation antihistamines.
Yeah, second generation antihistamine or nasal glucocorticoids, right?
Yeah.
Beautiful.
Okay, how about asthma?
PFTs.
PFTs, good. And I usually get the PFTs, but then what else do you do? I usually get an X-ray, but just empiric trial
Yeah.
of inhalers, right? And I think the same is true of emphysema. So somebody with COPD, I sort of handle them along the same lines. How about what about GERD?
Yeah, I think it's
Empiric PPI.
differential
Empiric.
by PPI and see if symptoms improve.
Good. What's the key to doing the PPI? For if you really think it's cough from reflux, do they usually show up with? Oh my
No.
gosh, I have this metal taste in the back of my mouth.
Nighttime cough especially, or like when they sleep or
Yes.
when they lie down.
So it's an atypical presentation of heartburn, and I do BID dosing for 2 weeks. So high doses for an extended period of time is an empiric trial. I think
You do
it's
40 BID.
yeah.
Okay.
And for 2 weeks. So a good dose of a PPI, and then have them kind of follow up. Sometimes they won't get completely better, but if they're getting better, then I'll bump it down to QA and then follow up and see how it's doing.
If they
So you didn't say, well, because it's kind of like on our list is post-infectious cough. That's really bothersome to a lot of people. That can go on for a couple of weeks. The bronchial irritation can take some time to get better. And
post
so,
pneumonia as well.
yep. So the only other thing I had on here was lung cancer.
And
So how are you guys skinning that cat? I know there was a bunch of concern about this new recommendation on CTs.
I started off with following the recommendations. I got at least 10 or 15 guys to get the CAT scans, but
How many pulmonary nodules are you following?
everyone.
Yeah. Okay.
So I think when Dr. Berim and Dr. Divan did this project about like how many are they following, what's the burden, it looks like it's an extreme burden even to
Oh.
follow up on these patients. Now I'm carefully trying to choose like those guys which I feel have like extensive smoking history, are still currently smoking, are those high risk guys. I'm not going and doing it, I'm just asking for their permission, and if they really seem that they're interested in doing it, then I'm saying it now.
That's how I've been scanning that cat, and then I've also been using that as if I have somebody that falls into that screening criteria and they present with chronic cough, I kind of push them into saying, you know what, you probably need a CT scan.
Exactly.
It's worth doing the screening in you, and it's not quite screening, right? Because they're actually coming in with a symptom.
Exactly. And
Even though
because it's tough on these guys too, because these are the guys who have emphysema and COPD and have chronic cough and that too. So it becomes
Yes.
so difficult. So we generally try to push them.
The final one that I always toss in there is that it gives me a beautiful caveat into, or a segue into saying it's time to quit smoking. And so if I say, boy, it's so bad now that you are falling into the category that we would be checking the CTs annually for, kind of gives me a little bit more weight behind my recommendation to say it's time to quit. If they aren't in that quit within the last 15 years.
So they had a really interesting study out that came out. It was done at the VA, and they looked at veterans' perspectives on what they thought about getting the CT scans annually. What do you think how did the veterans feel about getting the CT scans after they got it?
Unfortunately, gave them reason to keep smoking.
That's exactly right.
Yeah. Yeah.
A good chunk of them felt reassured.
Not
And so
cancer. Yeah.
it's exactly what we sort of feared, that they feel good, and a lot of it was they didn't quite understand that their risk of cancer hasn't changed because we've screened them. It just means that we didn't find anything today, but their risk is still there. So I think we have to make sure that we hammer that home. But anyway, so chronic cough I think is really straightforward. A good history and physical. You know, sick contacts, atopic things, asthma, allergy history to see if it's postnasal, empiric trial PPI if you suspect reflux, look in the history for things like aspiration, and then a good review of the medicines. And that's, I think most of the time you find a good answer. Sometimes it is troubling because the cough, a lot of times by the time they come and see you, the cough has been there for some time. You have to be patient with it. As long as it's improving and getting better, that's kind of the main thing.
Yeah. And like, just one last thing is like the homeless guys or those who travel to other countries, tuberculosis is another differential.
Yeah,
Chronic
absolutely.
cough.
Yep. What do we see here for chronic? So TB, we do have some cases here. What else do we see? It's in the soil. Histo.
Histoplasmosis.
Yeah, yep. Seen a couple of those. And they don't always have to be immunosuppressed. And right now we're actually going into histo season, right?
Yep.
Because they're going to start harvesting and they turn the soil over and it's going to be aerosolized. Okay, that's all I got.
Thanks, Rich.